In this week's Cardiology Countdown, we actually have 3 papers all published in JACC that begin with a very interesting paper looking at the idea of functional mitral regurgitation resulting from atrial fibrillation. This is a study done at a single institution at patients who underwent AFib ablation, and they looked at a cohort of patients who had mitral regurgitation, moderate at baseline, and had 1-year follow-up echoes where they found that patients who had restored sinus rhythm had a great reduction in the amount of MR, such that only 24% still had MR versus 82% of those who were back in atrial fibrillation. These were in patients that had normal valves, and thus raises the notion that atrial fibrillation may be a cause of some functional MR that can be improved with restoration of sinus rhythm. At this week's number 2 spot is a meta-analysis done by Greg Stone and colleagues looking at the issue of PCI with drug-eluting stenting versus CABG in patients with left main coronary artery disease. This has been looked at in various moderate-sized studies, and so they did a meta-analysis of 4 of them, a subgroup of the Syntax trial, also the Le Mans, the pre-combat, and an additional study. And they found that overall the strategy of PCI had a higher rate of TVR, overall 11% versus 5.4% at 1 year, but a lower risk of stroke compared with CABG, 0.1 versus 1.7%. There was no difference in the risk of death or MI between these 2 strategies. And thus the balance of choice has now a good evidence base from this meta-analysis. And at this week's number 1 spot is the publication of the CTSTAT study, which looked at patients presenting with acute chest pain felt to be low risk or low probability of actually having acute coronary syndrome, whether one could use a CT angiogram or myocardial perfusion imaging as a strategy to rule out coronary disease. They found that both strategies, and this was a study of about 600 plus patients, had equal outcomes in terms of risk of death, MI, etc., but that using a CT angiogram shortened up by 50% the length of stay in the emergency department down to 3 hours to make a diagnosis versus 6, and reduced cost by 38%. And so this is a moderate-sized randomized trial showing that this could be a very valuable strategy to use in evaluation of low-risk chest pain. So with this week's Cardiology Countdown, I'm Chris Cannon.